5, 4, 3.
Imagine you're looking just into a normal physician's waiting room of a doctor's office. There's two men standing there. One is wearing a suit and he looks nice. He has freshly shined leather shoes. His shoes match his belt and his watch. He looks professional. Maybe he's a professor or an attorney, a white-collar job. The other man sitting next to him is wearing construction boots, dirty jeans. He looks like he just came from his job as well, maybe a blue-collar job of some sort, a construction worker, something along those lines. The man in the suit clearly looks like he makes a little bit more money. They both have been recently diagnosed with type 2 diabetes. Each of them know about their diagnosis, but they're going in to learn more, learn about their treatment options, and just get the general information and their prescriptions. The man in the suit gets called into the office first. He's in there for about 45 minutes talking with the doctor. He goes over everything with him slowly, gives him a lot of clarity on his new diagnosis, really explains everything in detail. He even gives him his personal number at the end if he has any questions during office hours, when office hours are closed. The man wearing the dirty jeans gets called into the office next. He's talked with the nurse for a few minutes and then sits and waits an additional 20 minutes for the doctor. The doctor comes in, kind of rushes through the information. 15 minutes goes by, the doctor's out of the room, and he's left kind of feeling unsure about what to do with his new, recently diagnosed diabetes. In a 2013 article titled Adherence to Therapies in Type 2 Diabetes by Garcia Perez and others, they found that people that are of lower socioeconomic status do not follow treatment plans, as well as people that don't for type 2 diabetes. Their outcomes are not as successful. The doctor takes this information and spends more time with the patient that he thinks could make him the most money. He spends more time with the patient who's most likely to complete the treatment plan and have a good, successful outcome. As a nurse, I'm on the receiving end of a lot of complaints of patients. They feel like the doctor didn't spend enough time with them. They're asking, when is my doctor coming to see me today? And I have no answer for them sometimes because you don't really know anything more than they do. When you are being seen by a healthcare professional, you expect that they spend a good amount of time with you. You want them to answer your questions and take time. You don't want to feel rushed. If physicians were to be paid based on performance, this would be a very common thing. People of low socioeconomic backgrounds would possibly be treated not as well. Pay for performance or pay based on outcomes should be avoided for 3 reasons. Because it's difficult to implement, the tools to measure outcomes are too difficult, the concept of patient dumping is likely to occur, and psychological principles that extrinsic motivation crowds out intrinsic motivation are likely to occur. Some patient outcomes could be easy to measure, like blood pressure. If a person has high blood pressure, the next time they come in, their blood pressure is lower. That's a good patient outcome. They're getting better. That would be easy to look at. But then there's other types of care that's very hard to just set a hard and fast rule on, is this person getting better or worse. For example, a surgeon. Some surgeries take years before you know if this was truly successful or not. So a big problem with physician pays based on performance is when are we looking at this? Are we having the patient come back for years to the same doctor so we can see if they're really getting better? That's just not realistic. In a 2008 article titled Measuring Quality in Pay for Performance Programs by Mendings and McMahon, they discussed the outcomes of heart attacks. And heart attacks, one can happen, and then down the road 3 years later, maybe that stent that was put in wasn't effective and they have another heart attack. And the expectation that you're going to follow a patient for 3 years is just not realistic. The patient that I discussed earlier in the initial illustration that I gave was experiencing this phenomenon called patient dumping. In a Mendings and McMahon article, they define it as declining care for patient received as high risk for poor outcomes in order to improve the overall provider performance scores. So the provider handpicks the patients that they want to spend the most time with, or the cases that they want to take based on who could possibly have the best outcomes, because that will increase how much they get paid. Even if we did set up different plans or different measurement tools, they found that that still doesn't really translate well to patient outcomes, so physicians will still choose the cases that will statistically provide them with the best outcomes. So patients with socioeconomic lower statuses will receive less care, and it'll be harder for them to find care. The third idea is that extrinsic motivation crowds out intrinsic motivation. Intrinsic motivation comes from within. It's the desire to do good in what you're doing for your own resolve and for when no one else is watching. Extrinsic motivation, in the case that I'm talking about here, is money. So the physician is offered more money if they do their job better. And in a Woolhandler's 2013 article titled, "Should Physician Pay Be Tied to Performance?" she stated, "Rewarding performance ignores the complexity of human drive, particularly the role of intrinsic motivation, the desire to perform an activity for its own inherent rewards." So saying that if you offer someone more money to do something is just so simplifying the reason why people do things, because not everyone does things for money. This will work for some physicians. They will put in more time and more effort if they're getting paid based on how well their patients do, but for a vast majority of people, they won't get paid. It won't really work. So the example they used in the article was, if a person is hosting a dinner party and they're offered $10 by every person that comes to their dinner party, are they going to be more likely to have people over for dinner? Chances are no. People like hosting because they like hosting. You're not going to have your family over for Christmas because they pay you $10. You're just going to do it because that's what you like to do. Another example of that is kids, when they start playing instruments, they're so excited, they're teaching themselves things, but the second their parents are forcing them to go to lessons, they're a lot less likely to be picking up that instrument when they're being forced to practice. In a 2012 French study done on general practitioners, they said that we should be using extrinsic motivation like money with a great amount of caution, because it does have the risk of, as extrinsic motivation goes up, intrinsic motivation goes down. So doctors won't be doing things because they want to see their patients get better, they'll be doing it for the money. And that will also be attracting different types of people to the profession. I'm just imagining if nurses got paid more if their patients got better quicker, and that's a scary thought, because those aren't the people that I want to be working with. I don't want to be working with people that are doing it because they can get paid more if they put in more effort to a patient. Physicians should not get paid based on performance because it's too difficult to uniform. As I illustrated earlier, there's just no simple rule. It just isn't realistic. Patient dumping means that people of lower socioeconomical statuses would not receive as they won't be cared for as well. Extrinsic and intrinsic motivation have a huge impact on why people do the jobs they do, and it's been proven that extrinsic motivation will crowd out intrinsic motivation. If after all these reasons you still believe that a physician could provide adequate care and better care being paid by performance, it's just, there's no real reason that this would provide better care. The only evidence is that it would provide worse care in the long run. The ability to find good care would greatly be decreased